This is the Video Journal of Orthopedic Surgery, with our moderator, the professor and chairman of the Department of Orthopedic Surgery at the Medical University of South Carolina, Dr. John B. McGinty.
In this issue of the journal, our speakers are, from Baltimore, Maryland, Dr. David S. Hungerford, Associate Professor of Orthopedic Surgery at the Johns Hopkins University School of Medicine. From Madison, Wisconsin, Dr. William G. Clancy, Jr., Professor of Orthopedic Surgery and Chief of the Section of Sports Medicine at the University of Wisconsin. From San Francisco, California, Dr. Richard B. Welsh, Professor and Chief of Orthopedic Surgery at St. Mary's Hospital. And from Los Angeles, California, Dr. Edgar G. Dawson, Professor of Orthopedic Surgery at the University of California, Los Angeles School of Medicine. We begin this issue with Dr. Dawson, who will discuss the unstable lumbar spine. Low back pain is probably one of the most costly problems in American society. Will you put the problem of lumbar instability into perspective?
Jack, that question that you asked is a very difficult one to answer. We really don't know yet what the role of instability plays in the etiology of back pain and back disability. I have asked myself, what are we talking about? What is stability and what's instability? Do we really have any good definition of that term? You know, we use that term a lot to try and make decisions about whether or not our patients should have surgery or some other form of treatment. I think that the really good answer is in a definition that has been developed by Augustus White in Boston. And his definition of instability, which he calls clinical instability, is the loss of the ability of the spine under physiologic loads to maintain relationships between vertebrae in such a way that there is neither damage nor subsequent irritation of the spinal cord or nerve roots, and in addition, there is no development of incapacitating deformity or pain due to structural change. Now, I think that's a very good definition. Now, in order to really consider instability, we really need to know a bit about the spine. What are the forces that are acting on the spine? We have compression, tension, shear, or forward, backward, or side-to-side movement, torsion, which is a rotary movement, or usually, in the day-to-day activities of the patient, complex combinations of all of these. We really need to know, then, what factors resist these forces on the spine. In other words, what causes stability? In pure compression, or direct vertical loading, the disc primarily resists compression. In flexion, the anterior end plate of the vertebral body really does a lot towards resisting compression. And in extension, that vertical load is transferred to the posterior end plate and to the facets in the lumbar spine. Now, what resists these forces? In tension, in extension, it's the anterior longitudinal ligaments. In flexion, it's the posterior ligaments, including the ligamentum flavum and the various posterior interspinous ligaments. In torsion, it's the facet joints and the annulus that resist these forces. And if shear is applied, again, it's the facet joints and the annulus. What does a vertebral body do? Well, it primarily supports compressive loads, but the anterior one-third is quite weak. We've all seen that in patients with anterior compression fractures and osteoporosis. Interestingly, the vertebral body will deform 50% less than the disc will when under compression from a pure vertical load. There are factors creating stability posteriorly. The posterior elements, about 40% of torsional load resistance is in the facets. And interestingly, 25% of axial compression load resistance occurs in the facets. What does the intervertebral disc do? Well, the stress concentration in torsion is at the posterolateral aspect of the annulus. This has been shown many, many times. If you stop and think about it, that's exactly where most disc herniations occur that cause symptoms. Overall, about 40% of torsional load resistance comes from the annulus and the intervertebral disc. And the annulus is the major resistor of shear forces, or in other words, it prevents the vertebra from sliding forward, backward, or side to side. Very interesting studies have been done about what the disc actually does. If you create an annular defect such as you see here, certain factors will happen when load is applied vertically to that disc. If you remove the nucleus, other things happen. And if you take out everything, including the end plate, and apply a load, certain other things will happen. When the disc is damaged and a load is applied, very interestingly, when it's first applied and the only part that's damaged is the disc and not the end plates being removed, you will see a substantial increase in displacement along this line that you see. However, if you continue to repeat that, we don't know how, but the annulus has some mechanism whereby it will heal itself. And notice that after the third load, here, it becomes almost the same as when the entire disc was intact, so that the damaged disc does have a potential for recovering itself after it's been injured. There are other factors that create stability that we need to address before getting into the problem of clinical instability. The ligaments, the musculature, and the abdominal cavity. We don't know a great deal about the role of the paraspinal muscles, the abdominal muscles, and we don't know a great deal about the role of the abdominal cavity. I think that we should understand they do provide some stability, however, but the actual effect is unknown. There are a number of ligaments in the spine that we're all aware of that assist in creating stability in the lumbar region. The anterior longitudinal ligament is one of the largest and strongest ligaments in the body. As we come posteriorly, we really have another ligament, which is the annulus, fibrosis, and the nucleus. Then we come to the posterior longitudinal ligament, the ligamentum flavum, the intertransverse ligaments, the capsular ligaments, and finally the interspinous and supraspinous ligaments. When we see these ligaments, looking at them more in a like view, you will notice that the anterior longitudinal ligament is primarily the anterior half of the vertebral body. The posterior longitudinal ligament is very small and thin in the lumbar region, and then as we proceed posteriorly, we see connecting the spinous processes, the interspinous and the supraspinous ligaments, and directly in front of them, the ligamentum flavum. What role do these ligaments have? The anterior longitudinal ligament resists shear, torsion, and extension primarily. The posterior longitudinal ligaments do resist flexion, but as I will show you momentarily, they are biomechanically disadvantaged and not as effective as you think they are. The ligamentum flavum is one of those ligaments that we know a great deal about, but we have never really allowed ourselves to think about it as a main stabilizer of the lumbar spine. It is. In neutral, with the spine in a relaxed, normally lordotic position in the lumbar region, the ligamentum flavum is at about 15% of pretension. That means it will shorten 15% if cut. In extension of the spine, it only has 5% of pretension, and in full flexion, physiologically, it only goes to 50% of its maximum length. And you actually have to go to 70% of its length before it will fail. And it does have the propensity which the other ligaments do not have, in that it is elastic, it will lengthen, and then it will shorten back to its original length, providing continuous stability. An example here with the ligamentum flavum posteriorly, in between the laminae, as you go to flexion, at this point you will notice that the ligament can stretch, as we mentioned, up to about 70%. When you reach more than 70%, it will rupture. And if it ruptures, you've obviously had major trauma and created instability. Looking at this graphically, you will notice that the amount of load or strain, if you will, that is on the ligamentum flavum is such that in neutral it's at about 15%. And notice that it takes a lot of load, and until we get way out to about 70% and way up here, will it fail. So there's a wide physiologic range of the ligamentum flavum before it will actually be injured. I mentioned that the posterior ligaments, in other words, the interspinous and supraspinous ligaments, are biomechanically disadvantaged. If we take a look at a motion segment of the lumbar spine with two adjacent vertebrae and its intervening ligaments, we can make an analogy between this and a very simple mechanical model, where you have a center of axis of rotation here, you have the vertebral body here, and then you have a lever arm that comes out this direction. As we apply a load or bending in the motion segment of the lumbar spine that we're talking about, you'll notice that a ligament that is fairly close to the center of axis of rotation here cannot resist bending nearly as effectively as can some ligament that is displaced way posteriorly with a much longer lever arm. It's much more effective because the lever arm is twice the length. So we would thereby assume that ligaments placed posteriorly, in other words, the supraspinous, interspinous ligaments, would play a great role in providing stability. Something very interesting, however. In a study done by Rissanen in 306 cadavers, it was found that 21% of patients over the age of 20 had ligamentous rupture in the interspinous ligaments between L4-5 and L5-S1. And in those patients aged 31 to 40, 75% had rupture of the ligaments between L4-5 and L5-S1 posteriorly. I found that rather astounding that after the age of 31, that 75% of us have damage to our interspinous ligaments. It probably explains the origin of a lot of chronic instability. The facet joints, as I mentioned earlier, play a role in providing stability to the spine. In the cervical region, the facet joints are more oriented in a 45-degree angulation, which allows primarily flexion, extension, and rotation. As we go into the thoracic region, you'll notice that the orientation becomes a bit different. And then finally, down in the lumbar region, notice that they will allow 90 degrees of forward motion, but they will only allow 45 degrees of rotary motion to either side. Therefore, anatomically and structurally, these particular facets do provide a great deal of stability. How much stability do they all provide? I mentioned before physiologic loading. When we look at a spine with shear or anterior-posterior translation, if you will, we consider that 25% of movement anterior-posterior or 25% of movement medial-lateral is within the physiologic range. If it goes beyond that, we must assume that structural damage has occurred and therefore spinal instability has been achieved. A typical example, if we see a normal motion segment and severe forces are applied to it, if the facet joints fail or the pars interarticularis fails, then we will have instability. On the other side, if we have ligamentous failure, where the bony structures remain intact but the ligaments fail, should we see on a radiograph malalignment of spinous processes, malalignment of pedicles, or any shift of a vertebra in relationship, the one above or below it, greater than 25%, we must assume that major structural damage has occurred due to that particular injury. Now, what are the types of instability? We want to relate the types of instability to patients' problems. We have primarily congenital instability and traumatic instability. Congenital instability classically is spondylolisthesis. In a study reported by Fredrickson et al., they found that at age 6, the incidence in the population is about 4.4%. In the adults, it's 6%. Their study has shown, and many other studies have shown, however, that in the vast majority of these patients, progression is unlikely to occur. I have an example here of a patient with spondylolisthesis, the prototype of congenital instability of the lumbar spine. Notice that the spinous process is tipped way out so you don't see it. You can actually see almost a CT picture here of the lamina of L5, and I think you can see fairly well the so-called inverted hat sign. And what you're really seeing is the body of L5. If we look at this in a lateral projection, I think you can see that this is almost a spondyloptosis. The body of L5 is displaced about 100% forward of the body of sacral segment number 1. Now this clearly is instability by virtue of the fact that we have exceeded that 25% displacement that we arbitrarily said is the physiologic range. Is this truly unstable? According to most studies, it may or may not progress. Does that mean it's stable or unstable? By definition, we will have to say this is unstable. Now, there are traumatic types of instability. These are the ones that we see far more commonly in our day-to-day practices. We have the sudden onset type, which is obvious and it's acute. We have the gradual onset, subtle and chronic. And then we have the iatrogenic, which unfortunately is not so subtle, but often not too obvious until too late. Acute traumatic instability needs to be looked at in two concepts. We have the two-column concept long ago established by Holdsworth. Holdsworth felt that the vertebral body and its associated ligaments and discs comprised the anterior column, and the posterior elements, including the ligaments and the facet joints and the lamina and the ligamentum flavum, provided the posterior column. And complete disruption of one of these two columns was, by definition, instability. With our modern diagnostic techniques, the better way, other than Holdsworth's way of two-column concept, to look at the spine is a three-column concept recommended to us by Denise. In this, the spine is arbitrarily divided into three columns, and if two of the three columns are damaged, by definition, the spine is grossly unstable. The anterior column is the annulus, the anterior longitudinal ligament, and the anterior portion of the vertebral body. The middle column is the posterior longitudinal ligament, the posterior annulus, and the posterior part of the vertebral body. And finally, the posterior column is the supraspinous ligament to the ligamentum flavum, including the facets. To show you examples of instability, I would like to start by showing you an example of a patient who had gross instability. At the time of operation, when the skin was opened, you can see right in the middle that the supraspinous ligament is completely disrupted. As we go a little bit deeper, you'll notice not only has a dissection been done to strip all of the lumbodorsal fascia off the underlying muscle, but also you can see tearing of the interspinous ligaments. And as we get a bit deeper in, notice here that the ligamentum flavum is totally gone. It's all that's left here is a small blood clot in the dura. Is this unstable? By definition of either Holdsworth or Denise's classification in acute instability, it is unstable. Another example. Young lady fell, had this type of an injury. Notice spinous processes are separated. There is a clear-cut widening here. And if we look at this in a lateral projection, you will see that not only is the middle column destroyed, but also the posterior column is destroyed. This particular fracture, then, by our definitions, is unstable. Another example, a gentleman who was flying in a sailplane, missed the end of the runway, and had a hard sitting down type of injury with a direct fall from about 80 feet, creating a severe loading on the spine. You really can't tell, looking at this anterior-posterior projection, whether this is stable or unstable by our criteria that we've established. However, if we look at it from a lateral projection, notice the anterior column is destroyed, notice that the middle column is disrupted, and notice that the facet joints are dislocated. All three columns are destroyed. This is an unstable injury. What was done with this particular patient was that the spine was realigned and Harrington rods were placed to provide stability. We did not achieve realignment anteriorly. Should this patient have been fused and stability provided anteriorly, nature, gentlemen, often do a better job. Notice that this fused spontaneously and provided the needed anterior stability to give this patient full stability when he was fully beyond the time of healing of his fracture. Another example, a young man fell from a horse. Again, looking at the AP projection, you see that there is some abnormality here, but you really can't tell whether this is stable or unstable. If we look at a lateral projection, which is essential, notice that the anterior column is damaged. Notice that the facet joint is open here, indicating disruption posteriorly. We do have 2 out of 3 of our columns damaged. This should be unstable. If we look at this from a CT scan point of view, notice that there is complete damage not only of the anterior column, but also damage of the posterior middle part of the vertebral body, so there's middle column damage. And notice if we look over here that the facet joints are disrupted, there is posterior column damage, so this is clearly unstable and should be provided with internal fixation and stabilization. This particular patient had an operation where internal fixation was applied and an arthrodesis was done. And on a lateral projection, you will see that we have restored alignment, rigid fixation is applied, and now stability has been achieved. The other type of instability that we have that is traumatic in nature is that of chronic instability. This is the type that is seen more in the aging population. A number of radiographic tip-offs are there for us to know whether or not we're dealing with this particular problem. Traction osteophytes can be seen at annular attachments. We often see disc-based collapse, frequently asymmetrical. Degenerative spondylolisthesis can occur. Often these patients deteriorate progressively with time, and they may be painful. And I would like to reiterate, may be painful, because not all patients with traumatic chronic instability due to long-term wear and tear will be painful. Traction osteophytes, when they are seen at the margins of the vertebral bodies. They can be seen at a single level or at multiple levels. These are usually due to early instability, which causes traction on the attachments of the annulus to the vertebral body, leading to osteophyte formation. You can have asymmetric disc collapse, as I mentioned, and this in conjunction with the traction osteophytes that you see gives you a sign that there may be chronic instability, and perhaps the patient is on the way to degenerative spondylolisthesis or some other type of instability which may be causing pain, but again, may not be. I mentioned that these things are progressive and deteriorate with time. I'd like to draw your attention not to the obvious area of pathology here. In this patient taken in 1977, but notice higher up in the lumbar region here and here. Now let's jump forward in time. Let's take a look at what this patient looks like now some 9 years later. Notice that there's been deterioration here, which is predictable, but take a look here. That was an area that looked exactly normal, 1977. Now 1986, it is not normal. Take a look at it from the lateral. Notice the collapse of the disc base. Notice the traction osteophytes. Notice the retrolisthesis of this body on this one. This patient had pain, chronic pain. And I think that this individual had chronic pain due to chronic traumatic instability. Stability was achieved in this patient with internal fixation because of multi-level disease. Particular procedure of segmental wiring and Lukey instrumentation was done, and it provided stability. Notice that the instrumentation extends beyond the area of instability, and although the instability was not anatomically restored, the problem of instability has been solved by this type of fixation and by posterior arthrodesis. The last type of chronic traumatic instability that we need to discuss is that of iatrogenic instability. Many times a surgical procedure is performed and either the instability that is created by the operation is ignored or is not recognized. And as a result, at some point in the future, the patient develops symptomatic instability. We have here an example of a patient who had symptomatic lumbar spinal stenosis. The patient had a rather extensive laminectomy, L3 and L4. Postoperatively, the patient was no better. The reason she was no better, if you look at a lateral radiograph, is that the facets were resected, and notice that now she has a subluxation or spondylolisthesis of about 30% of L3 on L4. There are no posterior elements. Posterior column is gone. The middle column is gone by definition because it slipped more than 25%, so it's exceeded the physiologic parameters that we said create stability, and the annulus must be gone and the disc must be gone for it to slip this much. Therefore, we have a problem of significant instability. This brings us to the question of fusion. Arthrodesis, when do we do it when we have the problem of instability? What approaches are available? We have a posterior approach, a posterolateral approach, and an anterior approach. Through the posterior approaches, a fusion is achieved posteriorly. It can be done anteriorly through the posterior approach, the so-called posterior lumbar interbody fusion. The posterolateral approach, where bone graft is used to bridge between the transverse processes of adjacent vertebra and the sacral ala, is generally the procedure of choice for almost all of these cases of instability. It is biomechanically more sound than a pure posterior fusion. It is biomechanically more sound than a pure anterior fusion, and the rate of union in the literature clearly documents that this posterolateral fusion is the best to achieve stability of the spine in the patient who has instability. What are the indications for fusion? I believe that you must first show that spinal instability is present, which means primarily by radiographs. You must also prove that non-operative treatment has failed to either provide stability or to relieve the patient's symptoms. You must show that there is a high risk of displacement with physiologic loading. Now, what is physiologic loading? Physiologic loading is different for the elderly patient who sits around watching television all day as contrasted to the 30-year-old plumber who's going to be lifting heavy weights. So you have to take into proper context what you mean by physiologic loading. Fourthly, in deciding whether or not a fusion should be done, you must show that the natural history of that patient's condition is not expected to ultimately provide stability. And finally, that fusion of the segment or segments involved that you consider unstable will relieve the patient's symptoms. We must understand that as yet, we have been unable to establish a link between segmental instability that we see radiographically and back pain. The source of the pain in these patients remains unknown. We don't know where it comes from, whether it's facets, annulus, ligaments, muscles. We just don't have the answers. The question comes up, why do some patients with chronic instability have pain, and why are others painless? The information needed to answer those questions is not yet at hand. In conclusion, the recognition of instability of the lumbar spine is not easy. The role of instability as a cause of disability still remains unclear, and certainly further research is needed to clarify the multitude of unanswered questions that we have about the connection between instability in the lumbar spine and back pain.
Ed, is there any place in the use of flexion, extension, and bending films in the assessment of stability of the lumbar spine?
Physiologic displacement is considered to be 25%, whether it be anterior, posterior, or lateral displacement. For the patient recumbent on an X-ray table or standing, we see a static situation. In order to really see whether or not we have instability, I think it's wise to use lateral bend films or flexion extension films to see the amount of displacement so that we can really see whether or not instability is present or absent.
Ed, do you remember the days when we did spinal surgery and we used to grasp the spinal process with a clamp and rock it to determine the stability of the spine? Is there any place today to use that kind of technique to determine the indications of spine fusion?
Well, I think that's a good question. There's a lot of people that are still using that approach to determine stability. However, if you anesthetize the patient, paralyze the muscles chemically, resect some of the muscles and ligaments, and then mobilize the spine in an unconscious patient who's laying prone, which they would not be in any other circumstances, I find it hard to say that you can determine stability or instability with that method. In fact, it's probably a fallacy, because all spines under those conditions would move abnormally. So what's the point? It does not determine stability. That's something that should be determined preoperatively and not intraoperatively.
In your opinion, where does the patient's occupation and activity level fit in determining whether he should have a spinal fusion?
Well, we mentioned earlier that physiologic loading is one of the factors in determining stability. If you have a patient who's a heavy laborer working in the industry market where he's going to have to do a lot of heavy bending, lifting, things such as this, then I think that patient, if he has instability that's marginal right at the border lines of what we consider physiologic or abnormal displacement, then probably a fusion is necessary to keep that man working. However, someone who is quite sedentary, who's at the gray zone between stability or instability, probably doesn't need a fusion because their physiologic loads are much less than the aforementioned laborer.
Do corsets and braces provide stability for the lumbar spine, Ed?
Yes, they do. Some studies have shown that they increase the intracavitary pressure in the abdominal cavity and allow that particular abdominal cavity to become weight-bearing, so it does unload the spine somewhat. This is the mechanism by which it works. We know that there's very little in the way of immobilization afforded by most corsets and braces, however, so that it does provide stability by a hydraulic mechanism of increasing pressure in the belly, and that's the only thing it does. Would I use one, and do I prescribe them? Yes, I do, because I think they do relieve the patient with mild instability.
As orthopedic surgeons, we're constantly asked to give disability ratings for back pain. Where do you feel that instability fits in relationship to disability evaluations?
Well, I don't think we really know. As I mentioned earlier, we just have not been able to absolutely connect radiographic signs of instability with the causes of back pain. We have a lot of suspicions, but from a scientific point of view, there is yet no absolute connection. We just don't know why some patients hurt and others don't.
Thank you, Dr. Dawson. Dr. Richard Welsh discusses total hip replacement, state of the art. There have been many changes in total hip arthroplasty since Sir John Charnley introduced it. Dick, would you tell us where we stand today?
Well, today, Jack, we're in almost an explosion of technology. I think it might be pertinent to discuss some of those changes that are going on at this time in the state of the art of total hip replacement. Well, John Charnley started this back in the 50s with a total hip replacement. He, of course, is the founder of this technology, and indeed to him we are certainly indebted for the cemented total hip replacement and much of the research with cement. And indeed, one can still see in his practice cemented total hip replacements that have gone on for 15 plus years with indeed an intact cement mantle with very minimal to no radiolucency about the cement mantle. But of course, this is not in every case, and so cement has a significant failure rate in some series, 29%, and others 1.5%, depending of course on you consider radiolucent failures or x-ray failures or clinical revisions. Suffice to say, though, that we have identified a certain significant failure rate in total hip replacements and therefore the explosion of the new technology. First, however, we'll discuss the total hip replacement of the cemented variety. One can see considerable cavitation, as you see in this case of an ankylosing spondylitic, a young man who actually carried slabs of beef on his shoulder as he functioned as a butcher for approximately 8 years with a severe cavitation. The femoral side, too, can show rather significant cavitation and erosion of the femur with osteoporosis, and indeed this case one can identify a fracture through this osteopenic bone with a significant erosion in and around the cement mantle. Now, some of that is technique and some of it is method. I think with the new cement techniques and the new prosthetic designs, one should curtail some of the problems we've had with the cemented arthroplasty, and therefore I think it's pertinent to talk about the new cement techniques and new developments in the cemented arthroplasty first. Initially we talk about the acetabular preparation of the cemented socket. With acetabular reaming, fixation holes, cement pressurization, the cement mantle, which should be at least 2 millimeters so that you don't bottom out the prosthesis against the bone. A socket placement has to be in the anatomical area and not placed up high, increasing the forces as the prosthesis is placed high. And then metal backing of the sockets, which is certainly a new innovation. This is an example of a cemented socket. Here you have the old high-density polyethylene socket and the metal backing, both prostheses the anatomical level and seem to be functioning quite well. Metal backing has certain advantages, certainly theoretical advantages. With the use of computer modeling and geometry and analyzing the forces about the acetabulum, it's been able on a force diagram to identify the various stresses about the acetabulum. This is shown then on computerized modeling that the forces are markedly changed by adding a metal back to the prosthetic device. Seen here in graphic form, this is the summary of the compression forces with a high-density polyethylene socket as opposed to the compression forces of a metal back socket. One can see the evenness of the forces on the metal backing, therefore decreasing the stresses in the cement and the cement bone mantle. In tension, one can again see the difference between the high-density polyethylene socket and the metal back socket. Indeed, the forces are much more normalized on the metal back socket than seen in the high-density polyethylene socket. There are two areas in Zone 3 and Zone 1 where the forces are increased, but indeed the overall composite is a much more of a normalized force direction. Now, in shear, the same thing, if not even a better normalization of the forces about the acetabulum, stating then that metal backing of the socket seems to have a profound effect on the stresses of this composite of bone, cement, and prosthesis. Crown & Shield has shown and feels in his article in Journal of Biomechanics in 1982 that the stiffer metal-backed acetabular components are predicted to reduce maximum cement and bone stresses, at least in the laboratory. What about the clinical evidence of this technology up to the present time? Two series, Harris comparing his data with Doerr's series in a fairly similar case mix, however with one significant variant, and that is that on Harris's work they were all done by one surgeon using basically one technique, where on the Doerr series, the non-metal backed, the cases were done by a number of surgeons using various prostheses. Using a non-metal backed, one would say with Doerr, 30% loosening as opposed to the metal back of 9% loosening, given then clinical evidence that the metal backing certainly works. Unfortunately, again, Doerr's series did show that there were numerous surgeons and various types of prostheses being used. We also evaluated our data with patients under age 45 and having a similar mix and compared that with the Harris prosthesis. Now, we used a Charnley prosthesis, which is a rather thick prosthesis, and indeed our acetabular revision rate was about the same as the Harris prosthesis. Thus, it's really hard to say clinically whether metal backing has a definite effect. It would appear, though, to have a certain definite effect on very thin polyethylene sockets. In fact, as one reviews the old polyethylene sockets, the Charnley type, one sees very frequently an area of lucency in Zone 1. We really haven't identified what that lucency means. Is it too much stress? Is it too little stress? Is it a reaction to the acrylic? Or indeed, is it a reaction to the wear debris? Nevertheless, this, in long-term follow-ups of the cemented polyethylene sockets, is seen. We still, though, have not quite identified in everyone's mind what this excavation really means. But we do know that in the long run, that this will ultimately progress and cause loosening and many times cavitation, as you saw earlier on. Well, how then can we normalize the stresses around the acetabulum with a cemented total hip replacement? It has been shown now that preservation of the acetabular subchondral bone, metal backing of the acetabular component, thicker wall polyethylene components, and increasing the cement mantle at least to 2 millimeters decreases the stresses about the acetabulum. It would hope then, by decreasing these stresses, that one would then prolong the prognosis of a cemented acetabular socket. What about on the femoral side? Well, I think the most important thing that we've done on the femoral side are the superalloys. A number of failures were early on based on the poor metals that were used. Bending, breaking of the prostheses were seen. prosthetic design is improved, proportionality of design, the collar, and the Morse taper, and we'll discuss this. As I stated, in the first generation of total hip replacements, the Charnley, the Mueller, and the McKee-Ferrar, the metals were very inferior. Stainless steel, casted cobalt chrome, even casted stainless steel. And thus, some of the initial failures were from bent, cracked, and broken prostheses, causing too much stress on the proximal mantle of cement and ultimate failure. We now have the ability to use superalloys, where with the forged and the casted titanium alloys, much superior than the chrome cobalt and the stainless steel. We are now in a range where fatigue of this prosthesis should not be a real factor. The modulus of elasticity, too, is important. As we come closer and closer to bone with a titanium alloy, one should feel that the stresses should be normalized about this composite of prosthesis, cement, and bone, thus getting a more normal situation with normalizing the stresses, and titanium is a help in this area. Now, with design of total hip replacements, many designs have been shown to be marketed throughout the world. But there are some important factors in design that I think a clinician should look for as he chooses his prosthesis. A tapered lateral flange, I think, is important. The tapered lateral flange, as shown by Charnley in his original design, pressurizes the bone cement and provides compressive load transfer. This is important in the technical implantation of the prosthesis to get this cement to actually compress, and also compression is quite friendly to cement in that the cement is quite strong in compression and not quite as strong in tension. The femoral implant cross-section is important. In the early designs, all of these stem lengths were the same, 110 millimeter. Now, as these prostheses have been redesigned in the fourth generation, the prosthesis varies with the diameter, so that as the diameter gets larger, the stem length gets longer. Crown and Shield has also shown that up to about 150 millimeters, there is increased distribution of forces about the metal. So it's important in a larger person to use a larger stem, and in a smaller person, of course, a smaller stem. And now, with manufacturing techniques that we have today, we can do this and have this available for us. It is also important to maintain the load line. The load line is usually about 20 degrees in most cadaveric studies. Now, maintaining the load line is important because it maintains the abductor moment. Maintaining the abductor moment then normalizes the abductor force, so that as you bring the trochanter in, or in the valgus prostheses, you increase the forces about the hip rather markedly. By bringing it back out into a more normal situation, the abductor forces are lessened, and thus the forces about the acetabulum are decreased. This is very important, and with new metals now, we can do this. The load line is a function of neck length, neck shaft angle, and the center of head to long axis of the shaft. Showing this graphically, the neck shaft angle is important to preserve the abductor moment. The offset is important, and the load angle, again, the load line. All of this is the preserving this load line of about 20 degrees, which in effect then preserves the abductor moment arm and thus decreases the forces about the hip. One can see in this example, this is a patient's prosthesis of a third generation that is in a somewhat of a valgus position. The abductor moment arm, despite the fact that the trochanter has been advanced, nevertheless is not near as much as this prosthesis, which has preserved the load line, and thus the abductor moment is normalized. Now, clinically, it's extremely difficult to tell. This patient indeed has a good result on both sides. But it would make sense that this prosthesis, with a good cement mantle, with a metal-backed prosthesis and a preservation of the load line and a longer stem, that the forces about this arthroplasty should be more normal and therefore hopefully would last longer. But again, clinically, it's difficult to state. One of the most important additions has been the Morse taper to total hip replacement. The Morse taper, seen here, gives us the capability to vary the neck length and also the head size of the prosthesis. Thus, in revisions, one does not have to remove the entire prosthesis because of a scratch on the femoral head or because of an inadequate length problem. The Morse taper then can be used not only for total hip replacements, but can be used for bipolar indications and also for hemiarthroplasty or with a solid fixed head. This then, with the use of one stem, gives us the capability and the versatility to use it on various heads. This is extremely important, and I think will save a number of revisions of the femoral stem in time as we go into the next generation of revisions. Well, there are many factors in loosening: technical, mechanical, septic, biologic, and fracture. Orthopedics talk mostly about the technical aspects of loosening. It's very difficult to address the biologic factors. We all know that osteoporosis is a factor in aging, and one can study the femoral canals in older people, and you can see how the femoral canal, the endosteal canal, widens. So that as we discuss here, we must realize that when we're talking about technical factors, we're only talking about one aspect of loosening and not about the septic, biologic, and other factors that are present in loosening. In discussing the technical factors of loosening, we have some data that states that it is important with the cement techniques on loosening. In fact, a Mayo Clinic study showed that inadequate filling caused a 2.5 times greater incidence of loosening. A deficient cement mantle distal to the tip of the prosthesis also had an increased incidence of loosening. A proximal deficiency as well as a lateral deficiency again showed loosening. So therefore, cement factors are important in overall loosening. So then I think a pertinent discussion at this time would be the cement techniques on the femoral side. Removal of inadequate cancellous bone, brushing, water picking, drying, distal plug, centrifugation of the cement, cement delivery systems, pressurization, cement characteristics, and the surface of the prosthetic implant are all important in cementing a femoral stem. These were not considered yesteryear, and those are the cases that we're talking about the revision rate. We feel that with these cement techniques on a technical basis, we should improve the overall results. I think that it's important to use a model so that we may emphasize the cement techniques that we discussed earlier. The model will give us clarity in developing the techniques that are now being used as a status of the art. We're going to use this model to demonstrate the cement techniques. The femoral neck is osteotomized with an osteotomy saw and then is rasped and reamed in order to remove any of the cancellous bone and in order to seat a prosthetic device. One should use the rasp and reaming of that system that one is going to use. A trial reduction of the prosthesis is extremely important so that nothing catastrophic happens. It's important to know that this stem will go down into the intermedullary canal. A brush is used to remove inadequate cancellous bone as well as small and dead flakes of bone. Not seen on this video, but in the real situation, you can see tremendous amount of debris that is brushed away with the use of these brushes. This debris would be dead bone and would interfere with the cement bone bond. A water pick is also important. The water pick cleanses the proximal femur and opens up the cancellous spaces. It's amazing to see how clean the cancellous bone becomes and opening up the areas of interdigitation for the cement. Plugging the distal canal is very important. This not only stops excessive cement from filling up the distal femur, but also increases the injection pressures proximally of the cement when we pressurize it. A polyethylene or a silastic plug may be used. In doing this, one has to be careful that as you place the plug distally, you place it distally far enough, and also as you place it that you don't use excessive stresses because the plug too can fracture the femur. Indeed, a cement plug can be used. These plugs come with a measurement on the plug device so that you'll know how far you're down. In a very wide canal, In a patient with osteoporosis, we at times will use not only a plastic plug, but we'll also use a combination of the plastic plug and the cemented plug in order to obliterate the distal medullary canal. The cement plug in that type of a situation sometimes is not adequate, and neither is the plastic plug. Shown here then is the cemented plug, again placing it down the medullary canal, and then with the use of these gradations inserting enough cement. We usually use about 3 centimeters to 2 centimeters of cement, depending of course on the size of the medullary canal. Twisting the plugger, such as you see here when using a cement plug, is extremely important, for if you don't carry out this maneuver, one can bring back all of the cement with this device. Again, one has to be careful in utilizing a cement plug that the cement doesn't migrate proximally, and so it's best to use a trial prior to the formal cementing. The cement, after mixing, is poured into the cylinder of the cement gun. One can see the air bubbles in the cement as it's poured into the gun. And one thing about the centrifugation is that it eliminates this entrapped air into the cement, making then a stronger material for implantation. The top is screwed onto the cylinder, and then the cylinder is placed in a canister, which is then brought to the centrifuge and spun at approximately 30 seconds for approximately 3,000 cycles per minute. After centrifuging the cement then, the cement is brought back into the field and the tube is screwed on for cementing purposes. The cement is brought into the delivery system, and this has to be long enough to reach down to the plug in order to fill the cement from a retrograde fashion, trying then not to admix any blood in this. Prior to this, we usually fill the canal with an epinephrine fill sponge in order to stop any bleeding, and we also use a hypotension anesthesia in most cases in order to decrease the bleeding from the cancellous bone, and thus making a stronger composite when if there is no blood admixed into the cement. Here we are then bringing the tube out, filling the cement in a retrograde fashion until the cement is filled right up to the femoral neck. The nozzle is then changed, and the pressure nozzle is placed onto the cylinder. After placing the pressure nozzle on, the air is removed so that we do not entrap any air into the cement mantle, and then with firm pressure on the gun, the cement is pressurized. This then can be handled in a relatively liquid fashion, although we wait until the cement is rather doughy so that we can handle it and we don't get liquid cement all over the field. One can see the pressure being generated as the cement is pressurized with the cement gun. The excess cement is then removed, and the prosthesis is then placed down into this pressurized cement. One has to work rather quickly at this point in time so that the cement does not polymerize prior to the implantation of the prosthetic device. Pressures generated here can be rather enormous, seen in this modeling as the cement exudes out through one of the holes. In the body, of course, the cement is pushing into the cancellous bone as the prosthesis is driven down into the cement. Occasionally it will take a couple of raps from a hammer, gentle of course, in order to bring this down all the way to collar calcar contact. Again, excess cement is removed, taking care in this process that all the cement is removed. Using the cement technique seen, it's possible to get a rather uniform and routine cement mantle seen on X-rays. An example of this shown here, showing what appears to be an excellent cement mantle. Here we have a cement mantle going all the way down, good interdigitation into the bone, stopping here without any excessive cement, yet with an adequate cement plug. With the use of the cement gun, plugging, centrifuging, pressurization, etc., one gets an excellent cement mantle. And I think this is going to be important in the longevity of this prosthetic design. Well, I think it's important that we talk about revisions of failed total hip replacements. What is the success rate if a total hip replacement fails and has to be revised? Pellicci has shown in 110 cases with an 8-year follow-up that a 12% revision rate in that type of a problem. Kavanaugh showed his revision rate 9% with a 4.5-year study. And we, in reviewing our cases recently, with 104 cases followed 3 years, shows a revision rate of 5%. There are certain decisions we have to make when we consider revising a failed total hip. Whether to use cemented sockets, whether to use a cementless or a bipolar socket, and what is the fate of massive allografts used for reconstruction of acetabular sockets that have undergone considerable lysis. In doing the revision, the initial socket is removed, usually with the cement mantle intact. In removing the prosthesis, one must take great care not to lever with the osteotomes. For if you were to lever, one can fracture the acetabulum. Here you can see the cement mantle intact. At that point, one has to decide whether you want to use a cemented socket, seen in this case and in this example. This patient, an elderly man who had his initial prosthesis placed way up high on the ilium. He had very little bone left. He was a cardiac patient, about 80 years old, and it was felt not to bone graft, but rather to bring down the total hip replacement to its original anatomic place and use cement as the filler rather than bone grafting, with a good result. So thus cement can be used in revisions. One can, however, in another case shown here, with significant lucency about the cement mantle. This patient has had a loosened total hip replacement cemented socket on 2 other occasions. In this case then, we used bone grafting, seen here with a allograft, minching out the bone, making small areas of bone, and then packing it up into the defects, and then fitting this with a cementless socket using screws to fix this socket initially to the acetabulum. The result then, bone grafting the various defects with allograft and putting in a cementless socket. In some cases on the acetabular side, though, the excavation is tremendous. And additionally, there's very little bone to actually put in a cementless socket or a cemented socket. In these cases, if the anterior and posterior pillars are intact, a bipolar device can be used. One can see the bone grafting that has been used, an oversized bipolar has been used, and this case was then brought to a satisfactory conclusion by using the bipolar. These bipolars do not seem to convey a freedom of pain that is seen in the fixed sockets, but nevertheless they're certainly much superior than to a girdle stone or a resection arthroplasty. The fate of allograft in the salvage of large acetabular defects is still not known. Certainly they last for a period of time, but as they become revascularized, one has to question whether they will be the solution in the long run. Technically, one can do this, and I thought I would show a case of a massive allograft used as a salvage in a patient who had a congenital dysplasia of the hip, had 3 revisions, and now is left with very minimal bone. The patient had an allograft bolted to the acetabulum. The prosthesis then, with a mini component here, cemented in place into the allograft. As time went on, the allograft then became revascularized and started to collapse, as seen here. Further collapse occurred with the prosthesis migrating proximally. And finally, as you can see here, a total failure with complete loss of the allograft and the socket sitting into this area here. Indeed, in this case, the allograft totally resorbed, leaving a significant failure, and in addition, this had to be classified as an aseptic failure. The femoral component in revision, again, some decisions must be made. Whether to use a cemented or a cementless design, the length of the stem is important. Femoral defects and fractures, as well as bone grafting. These are decisions that have to be made. Some technical suggestions that I think we should advise: osteotomize the trochanter and use extra fixation in replacing it. Lateralization of the femur is extremely important in these cases because you have to get access to the cement and to remove it. And without good access to the proximal femur, one can window or penetrate through the femur. You have to remove as much cement as possible with osteotomes and be very patient. Divide and conquer are the key words. If you're going to use high-speed reamers, then you should expose the femoral shaft before using them so that you know where you are. It is possible with the use of an image intensifier or a fluoroscope to monitor your high-speed reamers, but you remember that your high-speed reamer is going at 100,000 RPMs and your fluoroscope is going at a click at a time. So therefore, you should, in my opinion, monitor the femoral shaft, and you don't really pay any price for this other than just some increase in the surgical procedure, such as mobilizing the vastus lateralis. One should span cortical defects in eroded bone by the prosthetic device. We've used 3 inches. That's certainly not a hard and fast rule. Another rule is 3 times the distance of the endosteal diameter. Whatever rule that you use, one has to span a major defect by enough metal or prosthesis in order to add stability to the femur so you do not get a fracture about this defect. Use a cement delivery system and monitor the cement closely. Monitoring the cement in these cases are extremely important with pressurization and the defects seen in revisions, you can get an awful lot of cement out into the soft tissues and not know it. Prosthetic orientation is crucial and anatomical landmarks may be absent. Because of the erosion of the bone, indeed the lesser trochanter, other anatomical landmarks may not be present, and therefore you have to be crucial on the orientation of your prosthetic device. And lastly, but probably most important, is that stability of the prosthesis should be achieved before closure. If you have impinging of the prosthetic device because of shortening, then one should acknowledge this and correct it. If the prosthesis is not stable on closure, after closure, dislocation may well be a real problem. I think one example of a femoral revision should be enough to show considerable number of these problems. Here is a patient who had a failed total hip replacement. The prosthesis has subsided. As you can see, there is considerable excavation. Indeed, what you can't appreciate here is this stem actually penetrates through the femoral shaft and out posterior. A lateral view makes this more apparent. One can see how the femoral stem is actually eroding through the femoral cortex with a large window present as the femoral prosthesis subsides down the femoral canal. Again, this prosthesis did not span this previous window far enough. Upon exposing the femur, one can see the large window present here with a large defect in the femur. Again, exposing the femur to get an idea of how large this defect is important. The revision showing the new stem down past the window with a bone grafting, in this case an autograft taken from the iliac crest, again using cement techniques, and an osteotomy of the trochanter. In this case, we used a cementless socket. What about fractures of the femur in and around prostheses? This, on femoral revisions, presents to the surgeon sometimes insurmountable problems. We have classified these and have devised a scheme to take care of problems such as this you see here with a significant fracture just distal to the stem. Fractures distal to the femoral stem, we would advise traction and cast bracing or open reduction and internal fixation. Indeed, you should concentrate on the fracture and not on the prosthesis. Fractures at the tip of the stem, however, are a difficult problem. In those cases, in our experience, they need open reduction and internal fixation. If you try to treat these closed, you get terrible alignment problems. Healing will occur, but then if you have to do a revision and you have a poor alignment underneath a prosthesis, the revision becomes enormous. So that we feel that one should do with fractures at the tip of the stem with displacement, an open reduction, and internal fixation, usually with a long stem prosthesis. Fractures around the femoral stem, these you can treat open or closed, but indeed, treated closed, they carry with it a 50% incidence of loosening. Comminuted fractures are very difficult. These are seen sometimes at the operating table when a prosthesis is tried to be jammed into the proximal femur. An open reduction, of course, is necessary. One should be very careful to conserve the bone stock and restore the cortical tube. In restoring the cortical tube, one has to restore it with a prosthesis in place, that prosthesis you're going to use. If you try to restore the cortical tube without the prosthesis in place, you may well restore the tube to a diameter that you cannot get a prosthesis down the medullary canal. So use the prosthesis as a strut, and then with either screws, wires, or whatever, bone grafting, then restore the tube and then use the cementing techniques. So the principles then are to concentrate on fracture management and prosthetic alignment. We feel that intermedullary fixation when possible, therefore a long stem prosthesis. Plates and screws are potentially hazardous when combined with prosthetic surgery, for indeed even with new superalloys, if in placing a plate you hit the prosthetic stem with your drill in trying to put a screw in it, you'll get a tremendous notch fatigue problem and the prosthesis can break. Plus, proximal fixation using the plates are not quite as secure, and there are tremendous forces about these fractures. So that you should restore the cortical tube with the prosthesis in place and monitor the cement very closely. This is an example of a patient who sustained a fracture of the femur just distal to the proximal stem. A plate was used, but one can see inadequate fixation was obtained. In that type of a case, we would use a long stem prosthesis with the same principle that an intermedullary nail in the femur is much better fixation than plate fixation. There has been an explosion currently of orthopedic technology. The cementless concept now has come in with tremendous number of ideas and hypotheses on what should constitute a substitute for cemented total hip replacement. One has to put this in perspective and realize that prostheses that were introduced just a couple of years ago, such as the Mittelmeyer Autofor, looking for a macro interlock, in our experience in San Francisco, has carried with a 2-year follow-up about a 30+% revision rate. 30% plus revision rate is not good enough to compete with the cemented total hip replacement. Many other models, though, are now being developed in this cementless systems. In this country, the prostheses that have been developed have depended more on micro-interlock or porous-coated technology rather than the macro-interlock that the Europeans have mostly developed. Both technologies are present, though, for cementless designs. You have to realize that these cementless designs are being developed in order to address some of the problems that we've seen earlier in the cemented femoral component and the cemented acetabular component. These prostheses then go by many names, such as the porous-coated anatomic, the HGP, etc. They're all prostheses that are based on a hypothesis of that man who developed it and the company who is selling it, trying to address the problems seen in the cemented designs. This, however, introduces a technology that is quite critical. The surgeon has to be very careful that he understands the limitations of this device as well as the technical demands on his skills. We are not using cement now as a grouting agent, and therefore the prosthesis of any cementless design has to depend on immediate stable fixation and bone that is juxtapositional to the prosthetic device so that the ingrowth concept can occur. If any instability is present, such as seen in this, the dislocation may occur. As you put in the femoral component, not seen well in this X-ray, but as you put in the femoral component, it has to be a tight fit, and fracture problems can occur. So that there is a considerable amount of technology and instrumentation that has to be developed. The cementless conceptual differences with the stem, titanium alloy versus cobalt chrome alloy. There are objections to each. A press fit is mandatory in this technology in order to consider any bony ingrowth into these pores, which in most of these cases are between 200 400 micra. The micro-interlock concept that we've discussed, the ingrowth substrate, whether it be titanium or whether it be titanium wire, titanium beads, or porous-coated cobalt chrome. And also its location is extremely important because of stress problems in and about the femur and the acetabulum. A straight stem versus a curved stem are an issue that is being developed. The length of the stem and the role of the prosthetic collar is still a consideration in the cementless prostheses. These then come in many shapes and fashions. Here is an array of a number of the devices that are currently being used in a clinical situation. As stated, the beads can be made out of cobalt chrome, or they could be made out of titanium wire or titanium beads. The micro-interlock seen here, the macro-interlocked with a textured titanium finish seen here. The porous-coated material this far down the prosthesis or merely up into this area here. Again, the hypothesis of the surgeon and the developer that is developing the prosthesis. A straight, longer stem or a curved stem seen in this situation. No one knows what prosthesis or what concept, or with all of these concepts, will hold. There is still inadequate data to really state what is the best prosthesis to use. The problem with stress shielding is being addressed at this time, with the porous coat being recessed in most designs more proximally than distally because of the stress shielding of the proximal femur. In the conceptual differences on the socket, the bipolar, of course, is one that is still being used in some areas. The sockets, however, some are threaded, some with screw fixation, some with impaction pegs, titanium alloy, cobalt chrome alloy, and the ingrowth substance again varies. Again, a sampling of prosthetic devices on the market. Some have conceptual differences that are completely different than the others. A cone type of design seen here, a truncated cone. A cylinder design in some cases, and the hemispheric designs. Most of the designs of late have been hemispherical with either impaction pegs for immediate fixation or with screw holes for a fixation immediate. But the whole concept is immediate fixation is extremely important if there's any hope of bone growing into the micropores, again 200 to 450 micropores. The approach to cementless in our hands is the use of a titanium socket with titanium fiber. We use screw fixation of the socket and use a socket that has perforations or holes in it so that we can truly see if the socket is bottomed out and is against the acetabular bone. We used a titanium straight stem prosthesis with the porous ingrowth material proximal so that we do not get stress phenomenon of the proximal femur with the resorption of the proximal femur. We also use either a posterior lateral or a transtrochanteric approach, being very careful to mobilize both the femur and an excellent view of the acetabulum. Here is an acetabulum that has been reamed. Again, one does not have to ream down to cancellous bone, but bleeding cortical bone is necessary in order to ream away all of the cartilage as well as any fibrous tissue. After getting a good, adequate acetabular bed, the prosthesis is placed in position and screwed in, and then the polyethylene liner is impacted in place. The femoral component, after satisfactory reaming, is then utilized, and the hip is then relocated and the wound closed. And now, let's review this technique on a model for clarity. The acetabular reamer is used, usually in step fashion, in order to remount the acetabulum in order to, again, seat the acetabular socket. The same principles of cemented systems is used in the cementless design, in that the cementless design, as well as the cemented design, has to be underneath the bone. After satisfactory reaming, the acetabular component is brought into the acetabulum. Again, the same principle with the cemented designs must be employed, in that the prosthesis must be covered by bone in order to distribute the stresses to the bony skeleton. This design allows the surgeon to know that the metal is up against the cancellous bone and there's not a space between the bone and the socket. You can see how the device is flush against the bone. It is important to know where the sciatic nerve is, for as you put the screws in place, it is important not to put them back into the sciatic notch. A drill guide is used, and the flexible drill is then used to place the first screw hole. Using the flexible drill can be a difficult problem initially, but certainly with the use of models, this is a technique that is mastered very easily. After drilling the hole with the flexible drill, the titanium screw is then to be implanted after measurement with a measuring guide. This screw is usually about 12 to 15 millimeters, and one should engage the inner table. This gives better fixation, but certainly one should not penetrate the screw too far. This drill guide prevents that. The titanium screw is then placed in position, firmly fixing the metal socket to the bone. As stated, one gets an excellent view of this as it compresses down, compressing the metal socket against the acetabulum. In our experience, we usually use 2 screws in a primary case, and in a revision, sometimes 3 and 4. The next screw is placed after removing the socket holder, and this screw is usually placed up into the ilium, where excellent bone fixation can be obtained. Drilling with the flexible drill, using the guide, and then with a titanium screw, again fixing the acetabular component. One can see the titanium mesh here very clearly, and also one can see the juxtaposition. The measurement of this screw is usually about 30 millimeters, and many times does not engage both cortexes, but rather is a cancellous screw. This screw usually fixes this metallic socket to the point where it is rigidly fixed to the acetabulum. This combination then of screws and screw holes in the socket allows one to be assured that the porous titanium is against, almost in its entirety, the acetabulum. After satisfactorily then fixing this against the acetabulum, here showing that we are up against the bone, the polyethylene liner is then impacted into the metallic socket and fixed. This fixation can be varied depending on the various devices used. It can either be a ring of polyethylene or it can be tabs of metal to fix it. It doesn't matter as long as the polyethylene too is fixed. Attention to the femoral side then is directed, and in this area requires a considerable amount of tooling and jigging. Somewhat unlike the cemented variety, the reaming must be done, but the reaming of the femur has to be quite precise. Indeed, one has to ream posterior, much as if you were putting in a Zickel nail, not as if you were putting in a prosthesis along the femoral neck. This has to be directed posterior so that one does not penetrate the femoral shaft. The rasp views also have to be specialized, in this technology because we are now depending totally on an interference fit or a press fit in the early going so that bone may grow into the pores of the prosthesis. This type of interference fit then is extremely critical, and one risks fractures of the femur as the prosthesis is impacted unless the proper sizing instruments are used. The calcar guide seen here is usually placed over the rasp, and a good calcar or proximal femur is developed. The neck and head is usually attached to the rasp so that a good trowel reduction can be done prior to implantation of this, the final prosthetic device. Again, these prostheses are quite bulky and need to be impacted down into the femur, and thus one has to be very careful that they use the tools that are designed for their use. The X-ray then, after the implantation of a cementless device, should look such as we see here. The prosthesis should be covered by bone and be set at the proper angle. These screws should not penetrate further than the medial table, certainly not any further in for violation of significant structures may be a problem. Again, the screw up into the ilium seen here on the cementless design, and the approximation of the bone with no lucency at all seen is extremely important in this technology. With the use of the collar calcar rasp, the collar should sit right on the medial neck. On the femoral side, the prosthesis should be stable, and this is why it requires the tooling in order to put in this intermedullary portion of the prosthesis to fix the prosthesis so that proximally where the porous ingrowth material is present, the bone can grow and fix this prosthesis again without cement. A frog leg lateral again showing this device in its position in the femur as well as in the acetabulum with good fixation. There is a problem with lack of long-term data in this cementless designs, and this is certainly one of the problem areas in cementless designs at this time. Stress shielding may well prove to be an extremely important thing with proximal osteoporosis and indeed lysis of the bone if stress shielding really becomes a significant problem. Stress fractures of the prosthesis also is a problem. We are now in an area with metallurgy that as the prostheses are coated with the porous material, they become much weaker. Indeed, these metals are not as strong as the forged cobalt chrome or the titanium, and indeed are down into the areas of tolerance that we saw earlier with stainless steel and chrome cobalt. Therefore, one should take great care in putting a very small or thin porous coated prosthesis because fracture is certainly a problem. The ingrowth material, how will it resist shear and stress? That too is a problem. Not only do we have to worry about bone growing into the pores, but also one has to worry about shear fractures of the porous material from the substrate metal. This can certainly become a problem with loosening as a result. Prosthetic fixation, long-term fixation. Is there enough ingrowth into these devices to actually ensure prosthetic fixation? We know that indeed, as looking at the prostheses, that only 30% of the prostheses overall are covered with porous ingrowth material. Of that porous ingrowth material, only 30% is actually available for ingrowth because of the bead size, etc. Now, of that 30%, there are only 30% in the laboratory using lesser animals have documented ingrowth material. Is this amount of ingrowth enough to fix these things in the long run? These are problems that we are dealing with. And then, of course, the last and also the most dire is the carcinogenesis and metal toxicity. We have a rather large surface area of metals, and certainly metal in small particles presents with a problem, although certainly the track record of orthopedic metallurgy has been quite good. There has been some concern, voiced by some, of carcinogenesis. Thus, in the long run, we have some concerns. What about the technical difficulties in implantation? This is a new technology and has to be considered as a new technology. And one has to spend the time to learn this technology in order to get a good interference fit without violating the femur. The fate of bone grafting material also is unknown as we make up these large deficits in bone and overcoming these cement problems. And revision techniques must be mastered to get these things in or out, for even though bone does not grow into some of these pores, fibrous tissue does, and it has been shown that some of these prostheses are extremely difficult to extract. Since 1967, when this technology was introduced into this country, there have been some sweeping changes. Not all change has resulted in progress, however. We do feel, though, that currently these devices, both the cemented technology and the cementless technology, have merit. Further time will tell how much we've improved over the original Charnley designs and implantation. Certainly, the cemented total hip replacement will have a place in orthopedics. I am sure that the cementless designs will be changed and will evolve. One thing is for sure, we will have change, and in addition to that, we must overcome the problems with excavation of bone, either from stress or from particulate matter or whatever the causation. The significant excavation that I've seen in the past has to be changed, and I am sure we will change it.
Thank you, Dr. Welsh.